And then he was talking something about the TB and DM. So I let him. The floor is yours.
Good afternoon, all. It is my great honor to present in the 10th HTAsiaLink conference. I am Nyi Nyi Zayar. I'm from Myanmar and also a project associate from HTAP, Thailand. So today I would like to present you about the study on programmatic cost effectiveness of the second home visit for detecting new tuberculosis and diabetes mellitus in TB contact tracing. So let's start with the background. Globally, 15% of the TB patients are suffer from the diabetes. Myanmar is in the 9th position among the country with high incidence of the TB comorbid with the diabetes. So in my country, to reduce the burden of these diseases, the government is implementing the screening program. So including the contact tracing of the TB among the household contacts of index TB patients, and also the screening of the diabetes among the high-risk patients that come to the health facility. And also, they are doing the bidirectional screening program of the TB and diabetes based on the WHO recommendations. So in my study, we conduct the contact tracing by screening of not only the tuberculosis, but also the diabetes in order to explore the hidden TB and diabetes patients in the community. However, poor compliance is one of the major barriers in the screening program. So the previous study on home-based diabetes screening done in Kenya reported that only 23% of the people with first-time DM positive came to the health facility to confirm the diagnosis. And also another study for TB contact tracing done in South Africa stated that they have done the repeated home visit to encourage the household contacts to take chest X-ray in the health facilities. So repeated home visit will be the one of the solutions to improve the compliance of the screening program. But on the other hand, allocation of the resources in efficient way is important, especially in the poor resource countries. And a previous study done in Peru also found that the multiple home visit is found to be cost effective, but this is a simulation study. So it also need to be examined by using the real world data by collecting the actual from the actual program. So in this study, we conducted the second time home visit during the contact tracing. And the objective of the study is to determine the compliance of the screening and incremental cost effectiveness of second time visit over the single home visit in contact tracing. So in Mellitus, this is a community-based contact tracing program in Yangon, done in single cohort of the household contacts of index TB patients. And so TB screening was done in all household contacts, and diabetes screening was done in household contacts more than or equal to 25 years old. So during the contact tracing, in the first home visit, we took the random blood glucose test of the household contacts, and also we provide the health education and counseling to the household contacts to take second time blood glucose test and the chest X-ray in the township TB clinic. And so if the household contacts, they didn't show up to the healthcare facility within 2 weeks, we conduct the second time home visit. So during the second time home visit, we provide the first time blood glucose test to the household contacts, and also we repeat the health education and counseling to take chest X-ray in the healthcare facilities. So the diagnosis of TB is based on the gene expert test positive, or the chest X-ray abnormalities is defined by the TB medical officer. Yes. And for diabetes, it is defined as a random blood glucose level more than or equal to 200 milligram per deciliter, and first time blood glucose level more than or equal to 126 milligram per deciliter. So in cost effectiveness analysis, basically cost effectiveness is combination of cost and effectiveness. So in our study, we use the standardized framework for the TB screening program for cost evaluation. So in this framework, there are 4 different components, including the human resource cost, capital cost, recurrent cost, and the overhead costs. The effectiveness in our study is based on the daily added value, which is the number of years lived with full health because of early detection of the new case. So based on the literature, the daily abided value for detection of the new case of TB is 1.88 years, and also for daily abided value for detection of the new case of diabetes is 0.038. So if we multiply this value by the number of cases detected in our contact tracing, we will get the total daily abided value of our study. So in our study, the primary outcome of the study is the cost effectiveness of the second home visit. So in order to compute the cost effectiveness of the second home visit, we use this formula, which is the difference between the cost of the two visit and the cost of the first visit divided by the difference between the daily abided value of the 2 times visit and daily abided value of the single home visit. And then we got the ISAR of the second time visit, which represent the incremental cost effectiveness ratio. This is the cost effectiveness indicator parameter we use to determine the cost effectiveness of the second time home visit. And then we compare this ISAR value with our GDP per capita in Myanmar in 2018, that is $1,250. If the ISAR value is lower than this cutoff point, the second time visit will be considered as cost effective. And then the probabilistic sensitive analysis by using Monte Carlo simulation for 10,000 iterations to evaluate the uncertainty of the parameters, which are compliance level, cost, and daily abided value based on their distributions. And then incremental cost effectiveness plane was used to represent the output of the Monte Carlo simulations. So in the result part, this is a summary table show the compliance level, operational cost, and daily abided value of after first home visit, second home visit, and also the total after the 2-time visits. So if we look at the table, the compliance of the screening after first home visit is 42.5%, and it's increased up to 76.9% after the 2-time visit. And then if we look at the incremental values, which is the primary focus of our study, so it's based on the second time visit. So the incremental cost of the second time visit is $1,989, and incremental daily abided value is 9.3 years. And then if we compute the incremental cost effectiveness ratio, the incremental cost was divided by the incremental daily abided value, and then we got the ISAR, which is $213.9 US dollar. So our cutoff level is $1,250 US dollar. So the ISAR value is much lower than this cutoff level. So it means that conducting the second time home visit is cost effective based on the primary data collection of the base case scenario. And then if we look at the output of the sensitive analysis, this is the incremental cost effectiveness plane. The x-axis show the incremental effectiveness, that is daily abided value, and the y-axis represent the incremental cost of the second time home visit. And after sensitivity analysis, we try to plot the output of each simulation on this plane. So each scatter plot represents the cost and daily abided value of the second home visit based on each simulation. And if we try to find the scatter point of our base case scenario, we try to plot the incremental cost that I shown in the previous table, that is $1,989 US dollar, and also plot the line for the incremental daily abided value, that is 9.3. And then if we compute the incremental cost effectiveness ratio, that is $213.9 US dollar. So in here, this scatter point represent the ISAR value of the second time home visit is according to the base case scenario. So here you can see there are multiple scatter plot. So each scatter plot represents the different ISAR values. That is the output of the sensitivity analysis. So as I mentioned before, the cutoff level, that is willingness to pay threshold level is $1,250. So this diagonal line represent the cutoff level. And so all the scatter plot represent the ISO value are fall below this cutoff level. So it can be said that there is 100% probability of cost effective by the second time home visit. So in discussion, after the second time home visit, the compliance level is increased from 42.5% to 76.9%. And also the incremental cost effectiveness ratio is $213.9, which is 82% lower than our cutoff level. This study also have a strength and limitation. So this is the first study to evaluate the cost effectiveness of second time home visit in contact tracing by using the real data. And because of the limitation of the study design and the availability of the data, we took the reference value for daily avoided from the other countries. So in conclusion, conducting the second home visit for screening of TB and diabetes in contact tracing was found to be cost effective. Thank you.
Thank you very much for a wonderful presentation. So you finished the first half of your job, but you have another half, which is Q&A. So let's turn to our commentator.
Oh, so thanks for that great presentation. I think it's really interesting to see this work, and it's really something which is clearly relevant to the health service in Myanmar. I had a couple of questions. So my first question is about diabetes and diabetes treatment. So you mentioned that there's a modeled QALY for TB and a modeled QALY again for diabetes if you have a screening program and if you detect. But I mean the benefit from TB is relatively easy to realize. The benefit from diabetes requires putting people on a lifetime course of treatment. So what are services for diabetes like in Myanmar? Is it likely that patients will actually get access to the sort of quality of services that they need to realize that health gain?
Yes. Thank you for questions. And so for diabetes, so in this study we use the daily avoided value. So it is based on the number of the diabetes patients that we detected from the screening program. So for the diabetes, there is a primary healthcare facilities in Myanmar. And so in primary healthcare facility, we provide the screening and the treatment. That is especially for diabetes and hypertension. It is free of charge, so they can access to these medical services at the primary healthcare facilities.
I'm glad you mentioned hypertension, because one of the questions I was going to ask was whether you screen for hypertension as well. I mean, that seems an obvious. I mean, that's easier to screen for. All that you have to do is measure people's blood pressure. So do you do that as well?
Yes. So actually, the study is a part of my thesis. So the thesis is focused on the comorbidity of the TB and the diabetes, which is the growing epidemics in the global. So in my study, so I focus on the TB and the diabetes. So yes, so in this study, I didn't screen for the hypertension. Yes.
Yeah. Oh, okay. And just a last question. So I see you've got compliance increasing from 42.5% to 76.9% when you go from the first to the second visit. Is there a case for a third visit?
No. Only 2-time visits.
But would you recommend trying a third visit? There's still 23.1% of the population whom you're not catching.
Yes. So if because our country is a poor resource country, resource limited country, so in my study I could only done this 2-time visit. But if they have the enough much resources for time and also the manpower and the money. So I would recommend to do the multiple home visit and then check for the cost effectiveness for further study. Yeah.
Oh, thank you very much. No more questions from me.
Thank you and congratulations for your research and the presentation, Dr. Nyi Nyi Zayar. My question is that other than repeated home visit to improve the screening or contact tracing, do you consider other methods as well? Now we have the digital technologies, for example, like SMS and others. Do you consider that? And who actually conduct the home visit? And during the home visit itself, do you actually do the screening, or is just to actually encourage them to come over to the clinics for the screening?
Yes, so the screening was done by the volunteer, healthcare volunteer. So yes, during the household visit, we screen the household contacts, and also we provide the health education about the how to say the TB and also the diabetes, and then we encourage them to come to the health facility to take the chest X-ray and also the second time blood test for the diabetes.
Okay, do you look into other methods to encourage them to come over as well?
So
home visit?
In my study, I didn't do any other intervention. So yes, only repeat the home visit. Yes.
Okay.
Thank you. Any other questions or comment? Yes, please.
Good evening. That's a nice presentation and very useful study for our LMIC countries like India. So just wanted to check with you once. So the setting of screening, why it is not considered to be in a facility rather than home visits? What was the difference in your setting? So anyone who comes with diabetes or TB is going to take treatment from a health facility like primary health center or whatever setups that are there in CHC or community health centers like that. So can we utilize that opportunity to screen for diabetes or compare it against the home visits? Will that be a better strategy?
So even to your questions, to my understanding is that can we do the screening at home without invite to the health facilities? Is it?
No. Can we do the screening in the facility, not at home?
Yes, we can do that. So that's why we invite them to come to the health facility for taking the chest X-ray. Yeah, and also for diabetes, we encourage them to come to health facility because they can screen in the health facility at the same time. Yeah.
Okay. Thank you.
Okay, thank you very much. Any other comments? I think this is a very interesting study, and if you guys would like to learn more, I think you can keep up with him later on because we have to keep the schedule in time. Okay, thank you very much, Nyi Nyi. Yeah.
Thank you very much.
Thank you.